Good afternoon, everybody. I'd like to welcome you to the Walls Lecture this week, which is the Robert S. Gordon Jr. Lecture in Epidemiology. I'm Paul Coates. I direct the Office of Dietary Supplements, and I'm also acting director of the Office of Disease Prevention at the NIH. And it's the Office of Disease Prevention that is the major sponsor of this particular lecture. It's been awarded now for 17 years to a scientist who's made major contributions to research or training in the field of epidemiology or in the conduct of clinical trials. And if you have the brochure, you'll see the extraordinary list of awardees. And it's no surprise that our current awardee is a member of that august group. The lecture was established in tribute to Bob Gordon for his dedication to the field of epidemiology and his distinguished service to the NIH over a long period of time. During more than 30 years of service at the NIH, he served in numerous senior leadership positions, including special assistant to the NIH director. His breadth of knowledge and experience in the clinical sciences led him to become chief advisor for clinical practice and research to 2 NIH directors. He was also an early organizer of efforts to address the emerging problem of HIV/AIDS and became the key NIH coordinator for AIDS research. This award lecture is named after Dr. Gordon in memory and honor of his distinguished career and unique contributions to science. This year's awardee is Dr. Jonathan Samet, who, among many other things at the University of Southern California, is also a pulmonary physician and an epidemiologist. He's professor and Thornton chair of the Department of Preventive Medicine at USC and also director of USC's Institute for Global Health. An international authority on the effects of smoking and air pollution on health, he's also used epi approaches to study a variety of different health issues, not exclusively passive and active smoking, but the epidemiology of lung cancer, health hazards of radon exposure, and indoor and outdoor air quality, to name a few. A remarkably prolific fellow and someone who is counted on to serve on advisory panels of many sorts, including his recent appointment to the National Cancer Advisory Board. Today's presentation, Big Epidemiology for Big Problems, ought to get your attention, and I think it is a very fitting tribute to this lectureship that Dr. Gordon would have been very pleased to see Dr. Jonathan Samet give this year's lecture. Please join me in welcoming him.
Well, thank you, Paul, for the nice introduction. And I'm honored to be here to give this lecture. I note that Gordon must have been a good epidemiologist since he studied at Johns Hopkins. Also in the days when it still had hygiene in the name. Now you might notice that my title here says to be determined. This was kind of the dilemma when I had the very nice call about giving this lecture. I always enjoy coming to the NIH. Like today, I had the opportunity to meet some new people, some new trainees, and to see many old friends and colleagues who I've collaborated with now for a very long time. So I was left with the quandary of what to talk about, which is where the title came from. There was this picture of me thinking about what I might speak to in the Gordon lecture. I looked at what this very distinguished group of people had talked about before, and I'm honored to follow in their footsteps. And as usual, I said, well, what am I going to talk about? And then, of course, for those who give talks, you always say, well, how can I take my last talk and turn it into the next talk? And I decided that maybe I wouldn't do that, and I would resist the temptation, so I'm not going to talk about any of the things you just heard about that I usually study. But I wanted to just, I guess perhaps because I can now consider myself an old epidemiologist, talk a little bit about some of the things I've seen and perhaps where things may be going in the future. So Hence, we have big epidemiology for big problems. Now, what is big? Lots of ways to define big. Could be from the health perspective, and again, disease burden. And of course, we have many looking at disease burden. We sort of see dueling disease burdens. For example, 7 or 8 years ago, when the tobacco control community became very upset because their primacy was threatened by obesity and inactivity. And some of you remember a bit of a food fight, so to speak, between the two communities. How many people are exposed? How big is the relative risk, costs, and future disease risks? And then from the research perspective, big sample size, lots of data, a new issue, big budget, and a big team. So many ways to define big, and I think, I guess I'm leaving big undefined, but I think as I wander through some examples, you'll see what I mean. And I think many of you now recognize that perhaps we are in an era of change. I wrote the abstract thinking that when we carry out research, and particularly epidemiological research, we're doing it with the thought that somehow, and not too distally, we're going to impact human health. And there's this sort of, I think, inherent contract between the investigator and the participants, society more broadly, that there's going to be a payoff. And I think, as I talk to people about what I do, they often say, well, oh, you're an epidemiologist. And then they raise some recent quandary. They're asked some basic question like, well, what should I eat? What's a healthy diet? How often do I need to exercise to live longer? And so on. And I think many of you have probably had that experience. So I think we have some big questions that we're sort of committed to answering. How quickly is perhaps another matter. So that's what I want to focus on today, are these big issues, big questions, big problems. I listed some of the kinds of things here that I know people care about, and some of the things that I heard today from trainees that they're working on, environmental carcinogenesis, an ongoing concern. We're always worried about yet what next chemical might be causing disease, or as we look at stored specimens or NHANES and find, in fact, that our blood is full of chemicals, admittedly mostly in small quantities, but what might they be doing to us? We're concerned about our children. We'd like to know what happens to veterans. I'm off from here at the end of the week to IARC, where there'll be a monograph meeting that is addressing electromagnetic radiation and the cell phone question. Again, with soon probably the majority of the world, perhaps from a very young age, walking around with a cell phone, we should be able to generate some information that will provide a sufficiently certain answer on this safety question. We've learned as we've developed our thinking about health that there are many determinants. This slide comes from a paper written by Tom Glass at Hopkins and a doctoral student at the time, Matt McAtee, and it's one of those sort of from the genomic substrate up to the global level kinds of diagrams. Not only does it go from the genomic substrate to the global, it moves. And through this masterpiece of PowerPoint, the point actually is that we're interested in what happens across the life course and trying to put these elements together to understand what drives human health. So there it goes again. Now, we need to start, I think, with a little humility about what drives health and disease patterns. This is the last century, mortality rates. And just as a reminder, here's infectious disease mortality. Here's the 1918 flu pandemic. If everybody remembers, penicillin comes in the late 40s. Anti-tuberculous therapy, the early 1950s. More modern antibiotics, the 60s and 70s. So here's infectious diseases dropping through basic public health improvements. Cardiovascular disease risks, of course, mortality, a triumph of prevention and therapy. Cancer mortality now beginning to drop after a rise that probably was largely driven by tobacco use. Stomach cancer falling away, likely as we improved sanitation and lessened H. pylori infection. So the imprint of epidemiology is here, but again, much of what drove advances in public health and mortality across the last century was simply the basics. Now, in thinking about how I wanted to present today, I realized that I'm not in Baltimore. I don't live in Baltimore anymore. This is one of the all-time Baltimore cartoons. It says, hey, what can I say? It's not Baltimore, but then what is? Because since moving to LA, I've now been asked the unanswerable question 1,000 times, what do you like better, Baltimore or Los Angeles? So for those of you who don't know where Los Angeles is, it's over there. And of course, I moved to USC, which does have a better football team than Johns Hopkins. Now, since I live in LA, I thought I would take a Hollywood approach to today's talk. So we're going to begin long, long ago. And some of you will remember these days. We're going to talk about the big problem wars. Let's not have a failure of automation here. In the prequel, there was the era of little epidemiology. And this, I think, is a past that many of us shared. Those were the days when epidemiologists could carry out small studies that answered big questions, like smoking and lung cancer, reproduction and breast cancer risk, and so on. And actually, in those days, one investigator could start one study and even finish it, and we did not have large multidisciplinary teams. Looking at the eras of epidemiology, in fact, early on, we were focused on germs and micronutrients, and a lot of important work done by single investigators. The turn to so-called chronic disease epidemiology beginning in the 50s and 60s as we recognized these new epidemics that were replacing mortality from infectious diseases. Social epidemiology, the era of molecules and genes, and now moving on to thinking about big things. So we're going to look backwards first. We can look backwards as far as John Snow, one person thinking about how cholera was transmitted. I'm not recommending the Cobra event. It just has this little synopsis that I don't actually like either about the so-called classic story of epidemiology. What's missing here is, in fact, John Snow did not remove the pump handle of the Broad Street pump, but he recommended to the council that it should be removed. So this, I think, is the dividing line between perhaps epidemiology and advocacy. But what he did was to collect data that allowed him to test the hypothesis that cholera was waterborne. The competing hypothesis at the time, remember, was the miasma theory, that there was this evil stuff in the air that was causing cholera. And this is simply his spot map of where the cases of cholera were and then the Broad Street pump. And I would actually recommend, if you do want a good read here, go pick up the Ghost Map by Stephen Johnson. And his reward, at least, the John Snow pub, which I have not been to. Has anybody gone to the John Snow pub and signed in? So some have. I guess this is really sort of the key thing for an epidemiologist to do. You probably had a pint or two as well, I hope, and toasted John Snow. Indeed. Okay. All right. Next trip to London. And then let me show you a different example. 1950, some of the early case control studies of smoking and lung cancer. Just as a reminder how simple these studies were, Ernst Winder did his study as a medical student at Washington University, St. Louis, working with Ewarts Graham, thoracic surgeon, the first to do a pneumonectomy for lung cancer. And here's his data, cases and controls. And there is no odds ratio here because the odds ratio had not yet been described as a summary effect estimate until it came a few years later with Jerry Kornfield's paper. In fact, here's the entire data collection instrument that was published in JAMA. Think about trying to publish your 100-page dietary instrument or exposure assessment instrument along with your article these days, or at least in hard copy. So to characterize smoking, you don't need much. And here, at what age did you begin? At what age did you stop? How much did you smoke on average? Do you inhale? Do you smoke before or after breakfast? A good question, it turns out, for addiction. Now, smoking was a good place to get started with a lot of epidemiology. It's what I call a good risk factor. It's easy to measure, and it's unfortunately tragically powerful, as we all know, in its consequences. So Winder and Graham and others were successful, and you understand what happened. Richard Dahl, involved, of course, with Hill in another of the early case control studies in London, becoming convinced from the case control data that smoking must be a cause of lung cancer, but thinking that prospective data would be needed to set aside those who were critical of a seemingly retrospective approach to data collection. And he, of course, with Hill, implemented the British doctor study, again, a very straightforward study, questioning physicians about their smoking periodically and tracking them for mortality, a model that, in fact, underlay Frank Spizer's initiation of the nurses' health study. And again, of course, many, many powerful conclusions coming from this study. Another important outgrowth of this early work, Levin, who did one of the first case control studies later at Hopkins, said, I think smoking causes disease, and if something causes something else, I want to know how important a cause it is. And he proposed the attributable risk, which we still use and underlies conceptually our estimation of disease burden and risk assessment. So again, a powerful idea coming on early from an epidemiologist in those days. This is actually a picture of the Hopkins Department of Epidemiology in the mid-30s. I used to show this to my faculty when I was at Hopkins and point out how well dressed the faculty were at the time. And Wade Hampton Frost, possibly the first academic epidemiologist, is shown there. Now, just to say a word about my career, which started after 3 years at Harvard in New Mexico. When I first went there, this cartoon actually was in the Albuquerque Journal. It describes Blanca Avelina Aragon of Blanca, New Mexico, who is still rolling her own cigarettes at age 104. We probably should go find some of her genes and find out how she was able to do that. But I became interested in the patterns of respiratory disease in the state's Hispanic population. And that led to, let me go forward, a case control study, my first NCI grant, to look at why rates of lung cancer were lower in Hispanic or compared to non-Hispanic whites in New Mexico. I had many interesting hypotheses. The answer, of course, turned out to be smoking, and we were very nicely able to show that the risks were lower in Hispanic smokers because they smoked less, not so surprising. And here, a simple case control study done in the Navajo showed that most cases in this non-smoking population were attributable to uranium mining and the associated radon exposure. 32 cases, 2 controls per case, and the unique circumstance of finding no exposed controls with 70% of the cases exposed. The youngest miner, former miner with lung cancer in his early 30s. This is a group that had very high radon exposure from an early age. Simple, small study, main point. So at that point, we were on the power curve where with relatively modest sample sizes, there was good power even for studying relative risks in the range of 2 or less. So there were triumphs, and I've just listed some of them here. the study of DES and adenocarcinoma of the vagina. I think the original case number is 13. If I remember right, it was a study with triplets, some very small, powerful studies. In fact, if small studies are powerful, we're probably finding effects that are too big. So these are problems that needed to be found and identified. So let's move on to now what I would say an era of transition. And we're being driven by technology in part, very large data sets, genomics, abilities to do computation that we could not even think about before. When I began my career, I carried my data around in a box of cards to the Harvard Computing Center. One of the worst things that could happen was to drop your box of cards, of course. And I learned early on after doing that you needed to replicate it right away and put a box away. So what are we up to these days in epidemiology? Well, we're doing a lot. And if you just simply go to PubMed and say, how many studies are there with epidemiology? The answer is a lot. So we're heading for 100,000 papers a year, roughly, with the search term epidemiology. Just showing you where we are most recently. HIV/AIDS in the 3,000-4,000s. And again, powerful answers coming there from epidemiology. Colleagues who started, for example, the multi-center AIDS cohort study early on before we had a clue as to the cause. Diabetes, following what is there, which epidemiology always does. Obesity. Look how quickly, as the epidemic has moved in, the epidemiologists have followed. Genetic epidemiology. And last but not least, GWAS. Okay, now some might predict that perhaps this number will go back down, but I think there's still a rising tide probably of unpublished papers coming from our GWAS that will keep this up for a while. And then what I see as a form of epidemiology, clinical translational research, a new term now being driven, of course, by the CTSAs, the Clinical Translational Science Awards that are moving us to use this terminology. I want to say a little bit about some of the kinds of transitions I've been involved in here. Some of you may have seen this picture before. This is the group that pooled the data from the uranium miner and other mining cohorts. This goes back into the early 90s. Here we were seeking to answer one of those big questions. What were the risks of radon? What was a safe level of radon indoors? And the way to get at that was to pool the data from all the cohorts. So at the lower exposure range, we could begin to see what the shape of the exposure-response relationship looked like with some certainty. So this slide comes from taking the minor data at the lower end of the curve and looking at what the risks were. So stretching down here into the range of homes. And then again, just to go back in history, Jay Lubin here, John Boyce, Jeff Howe, Ted Radford, and others. It was also a time when we began to share data. And I'll come back to that theme, but again, that's part of this move with so-called big epidemiology, is to put all our data sets together. And here, we did that readily because we knew that we were not going to be able to describe this relationship that everybody needed described from our own data. The NCI cohort consortium, including some folks in the room, the GWAS findings, again, moving to put together large bodies of cases and specimens to see what we can learn. I've been fascinated by watching the emergence of these studies. I think, of course, we've learned it's not as easy as we thought it might be to identify important associations. And I will say that as I hear the critics in retrospect saying, well, why do we ever do this? Personally, I think this was a needed step as we transition to where we're going now with more sophisticated sequencing techniques. In my own work on air pollution, we began to move to look at very big compilations of data. So with my colleagues at Hopkins, Scott Ziegler and Francesca Domenici, as we tried to look at the risks of air pollution in the United States, we turned to national resources. The monitoring system maintained nationally by EPA, plenty of information on weather, using Medicare to look at hospitalization and air pollution across the country, using data from hundreds of cities at a time and not just one, creating cohorts of 20 million plus Medicare enrollees who we could then track for events in relationship to air pollution. So this is an example of one paper from that work. Again, here we put together data from the 20th largest cities in the United States. I'm showing you a prior probability distribution of the likely effect of particulate matter in the air on mortality, with and without adjustment for other pollutants. And the main point here was that regardless of our consideration of other pollutants, an effect of particulate matter remained. This was data based on data from 54 million people, something that we could not have done 10 or 15 years ago. My first time series study on air pollution I published in the early 80s in one city was technically challenging and computationally challenging at the time. That certainly changed. And then bringing data together from multiple sources. And this is an effort where we pooled all the air pollution time series data from around the world to get that global picture. Now, the work has also, I think, become increasingly multidisciplinary. And again, I'm going to stick with air pollution and what I know for the moment. As we looked at air pollution across the country, we mapped the risks to people within cities, doing time series studies within many, many different cities, and produced something that looked like this. So what you're seeing here is the effect of particulate matter on risk for hospitalization in different regions of the country, showing that there's some variation in risk from high to low within a region. What we did then is we went to each of these regions, each of these cities, one high, one low, and we collected particles from the air with this gadget. And then we've done a number of things with those particles to try and characterize them. Chemically, we did detailed monitoring of the air pollution alongside these sites. And we've used the particles in mouse models of human disease. So we have a heart failure mouse, this Krebs mouse. We also have an asthma model. These are both well-established models. And what we're doing now is putting the particles in and asking the question, looking to see if there are differences in response in those cities where we see a greater risk in people compared to those where the risks are lower. And this is leading to some interesting findings. We're just finishing this up. My colleagues at Hopkins also developed the idea of reproducible research. This research has been high profile because it addresses big issue. What are the risks of air pollution? And there are many people stakeholders who would like to have access to our data. And we developed data sharing mechanisms, proactive data sharing mechanisms, making software and data available through a website. And last time I looked, over 20 publications had come out based on this literature. And I think putting the data out there in this way, I think, has made our findings hopefully more robust as others have moved forward. And then I think we've entered the domain of big studies. Just for example, with the National Children's Study, now launched. At one point I was on one of the early advisory committees for the study. It was very threatening to realize that I was on a study where the primary outcomes would probably be looked at long after I was gone. So it was an interesting experience. And we've seen other changes, and I'm going to come back to these science culture changes. But one is a difference, changes in the way that we do science, changes in the way we write papers. And this shows simply the rise of the number of multi-authored papers. Papers, for example, with greater than 500 authors. So changes there. So let's look to the future, to sort of the coming attraction, I think arguably the future is starting now, or maybe it's already started, and I think we can all question what it is. It seems to involve things that end in omics. I made up my generic future omics. And how are we going to do this, and how are we going to meet the challenge of translating all this data into answering the questions that society wants answered? So one, I think, really new challenge is the fact that we can generate an extraordinary amount of data about one person. And just some easy takes on this: the genome, since I'm from USC, the epigenome, the microbiome, the exposome, I didn't make that one up, and of course there's many more to come, and I haven't listed, but think about the billions of data points that we are generating about single individuals with the idea that we're going to answer questions about their health and disease risk. This article by David Schwartz and Francis Collins a few years ago in Science, talking about our new technological ability to generate information about what people are exposed to. So probably soon with our cell phones, we'll keep track of where we are, how much activity we are. Think about it, perhaps taking pictures of our food for later analysis of what we've been eating. And it could go on and on and on, our ability to collect data. And somehow we're going to have to put this together. So coming with this ability to generate all this data, I think are some, what I would say, very big end questions. Personalized medicine itself I see as a very big end question. It's reducing all that data about one person into something that a person and their healthcare providers can actually use. And how are we going to do that? Gene by environment interaction, in a sense, personalized medicine is in part thinking about gene-environment interactions. Life course epidemiology, trying to generate the most healthy babies and children and then adults that we can. Environmental carcinogenesis, which is, I'm sure, will stay, and I know you could all add to my list. Just as an example of the big N challenge, the sample size needs for gene-environment interaction, and there are many takes on this. This one, this particular plot comes from Duncan Thomas, a colleague at USC, looking at sample size needs if we have a candidate gene by environment interaction we're interested in, whether we're in the GWAS context and what we think the interaction effect is. And I think the bottom line here is, as you can see, we get into very big numbers, tens to hundreds of thousands. And this is without acknowledging some of the inherent flaws in the data, our measurement error problems related to exposure and to genes. So these are very big N questions. As I was putting this talk together, this issue of Science arrived, which if you haven't read it, I think is a great introduction and coverage of the big N, the data problem in many, many different fields of inquiry. So the issues I'm talking about have a lot of commonality, and I think they're nicely covered here. So we had the arrival of big epidemiology. Now, I'm going to talk a little bit about the consequences of this arrival. Some years ago, I think, Bob, it was 2007, we did a symposium at one of the epidemiology meetings on big epidemiology. We thought it was the time to use big and epidemiology together. And Bob gave a wonderful overview from cottage industry to big science. And I think I sort of started you back in the cottage industry days, and we know where we are with big science. Now, one paper that resulted from this was called How Big is Big Enough for Epidemiology? Because I don't think I've ever been at a meeting involving epidemiologists where there was as much emotional response to a set of presentations. And George Kaplan, who was then chair of epidemiology at Michigan, stood up and gave an eloquent speech about the fact that big epidemiology was probably to be tolerated but should not obliterate the rest. And person after person stood up and gave the same message. And I think that Bob was, as the messenger, I think, probably the recipient of much of the heat. And I was moderator, and there's actually very little I could do to rescue him. And I think he's still a little bit bruised if you mention big in epidemiology around him. So George wrote about this. And then Roberta Ness, who's now dean at the Houston School of Public Health, and I think a wonderful thinker and commentator, wrote this piece, Big Science and the Little Guy. And as somebody who chairs an academic department, has done so in the past, I think this is one of the real issues for those working in the field. So what about this big science? What about all the pre-docs and post-docs I've talked to today and big epidemiology? What does it mean for your lives? And I think there's a lot of issue. I made this up, the American Journal of Big Epidemiology. We may need a journal, in fact, that can tolerate author lists that sometimes run in the hundreds. I recently met with all of my faculty, and it was quite interesting talking to those who do work in the genomics area, because I saw things I had not seen that maybe are becoming commonplace to you. Shared triplets of first authorship, quadruplets of senior authors. So you have a paper that has 3 little asterisks at the first, and there's a huge block of names, and then down here there's 4 more little different symbols. Or those people who are in the middle, who have like 2 authors, and then ... them, and ... the end, or else they have a page and a half of their CV given over to one paper. I was talking about the early stages of my career when I was pleased when my CV went from 1 page to 2 page. Think how easy that's going to be in the future. So lots of issues here in our day of transition to big epidemiology. Career issues, becoming an independent scientist in the face of this transition. What competencies are needed for those moving into this new era? Do they have to be able to do a cohort study? Do they need the ability simply to go to the web and download data or be part of a consortium? Are they going to be a team member or a team leader? And how do they gain credit for contributions? And as somebody who writes a lot of promotion letters, it's becoming more and more challenging, particularly if the committee includes a lot of bench scientists who think in a different way. So I think this is a challenge ahead for our team, for our academic culture. And I'm at a university, like all universities, that talks about big science, team science, multidisciplinary science, but that hasn't drilled down yet to the promotions and acknowledgement process. So I think there's work to be done here. So I've never liked this changing paradigm discussion, but if this isn't a paradigm shift, I'm not sure I know what is. So where are we moving to? So maybe to doing more studies through health systems-based research and electronic health records. Recently hired a clinical informatician into my department to work on these issues. A lot of discussion about systems approaches, trying to think about this big picture and where the epidemiology plays in. So epidemiology becomes one piece of a broader puzzle of disease treatment or diagnosis or prevention. Data sharing and data access. Here, perhaps reaching epidemiology piecemeal depending on what kinds of work people are doing, but here. Ideas of research as a public good and accountability. And more networking and networks as we use better and better tools to do so. So let me just say a few words about each of these shifts. I'm fortunate to have worked now for more than 10 years with a colleague in Korea, Soonha Ji, a former postdoc at Hopkins. Soonha has access to a population of 1.3 million people. They're Korean civil servants and teachers who answered lifestyle questionnaires now ranging almost 20 years ago. He has all events because Korea has a national health database. So we're able to publish papers, this is just one example, simply tracking outcomes and exposures through record linkage. So for example, we're able to define incident diabetes based on blood sugar or prescription medications. And this is now available for the population. And of course, biobanks, and again, we'll have to see how large and how many we have. But again, tools that are going to be important. More and more networking and proactive networking. This is an example. And tools to understand networking. This is a fascinating plot from one article in that issue of Science on so-called meta-knowledge. And it's looking at how communities of scientists interact. I think the goal in the end is so we have better ways to enhance those interactions. The purple is one group of scientists working on these organic, critical organic molecules. The green are those working on neurotransmitters. And the blue are the bridgers. And this is showing the networks and how these scientists relate as they publish. Think about this internationally. So I think we'll have power in our ability to understand these networks and hopefully to enhance big research and big epidemiology. So back to this. I think we've learned that if we want to use what we are finding in our epidemiological studies to enhance health, we really need to understand at one or another level much of what Tom Glass and Matt McAtee put into their diagram. Tobacco is a great example. On the one hand, we're very interested in exploring the mechanisms and pathways of addiction and disease and determinants of disease risk. And on the other hand, we know at the global level, the industry is largely a handful of multinational corporations, and that control lies in having measures that combat those corporations. Now we have the Framework Convention on Tobacco Control in force for over 5 years, the world's first public health treaty. So I think this model serves us well. It still moves. And I think as we look then at how to use epidemiology, you'll see more and more so-called systems approaches. And I think what is useful in these kinds of diagrams is to understand where epidemiology fits in. Let me show you a recent example from my life. I spent a year working as chair of the Tobacco Products Scientific Advisory Committee at FDA, trying to understand the public health impact of menthol cigarettes. Early on, we put together a very simple model of how menthol cigarettes might affect public health, whether adversely or not. And this actually became the basis of some modeling we had done on burden estimation. What was useful here was that we could define where epidemiology fit in, where other kinds of sciences fit in, where what we learned from looking at marketing fit in, to understand the public health impact of menthol cigarettes. So the epidemiological questions largely related to whether the risks for those who smoke menthol cigarettes were different from those who smoke non-menthol cigarettes. Other issues related to whether menthol affected initiation or likelihood of cessation. And we use survey data, of course, to describe patterns of menthol use. This will be an ongoing story. If you're interested, Neil Benowitz and I just had this article published in the New England Journal describing the findings of this committee that worked very hard in a year to put together this systematic review and estimation of public health burden. So the times are changing. Team multidisciplinary science, many authored papers, data access, and data sharing. I will say early on in my career, I don't think I wanted to share data. You spent years collecting the data. Our New Mexico uranium miner cohort was 10 years of data gathering. It was going through old sheds at Ambrosia Lake, New Mexico, looking for lost uranium industry articles, going through the state archives, looking for the work of the state mine inspectors, and so on. And after 10 years and one paper, I wanted to see at least if I could get another 1 or 2 papers. Data sharing was not what I was thinking of, and my viewpoint has, I think, changed radically. consortium mechanisms, potentially mega studies, new disciplines, bioinformatics, a word I was not using 20 years ago, and now in my department at USC we have a new division of bioinformatics. The accountability issue. And coming with this, implications for training. I think in epidemiology we're still mostly training the way we used to. And it's probably time to do some rethinking. I'd be interested in what others are thinking about this, but I'm convinced that there's probably other things we need to be doing, other competencies we need to be building in our graduates. I thought of this around biostatistics too. We have a biostatistics PhD in my department. We'll likely start one in bioinformatics. Is that the right thing to do? Isn't there a continuum? And how do we bring this together? So I think as a field we need to talk about this. Accountability is an interesting word, and it's one I've heard a lot in sort of the public policy sector I work in around air quality. There, air quality has improved greatly. In LA, I have a great view of downtown and the mountains. I think for years I came to LA without even realizing how close the mountains were. And now they're there. Downtown is always visible. If it gets a little polluted, I know exactly because the buildings begin to fade a bit. Ozone levels are down remarkably. This issue of accountability has come. It's come from the Congress. Air quality has improved. What are the benefits? How many lives have been saved? How many dollars have been not spent on healthcare costs? And here, there's been some thinking about the methods. In air quality, I worked with the Health Effects Institute and putting together some frameworks for thinking about this issue. But I think this word is one that we're hearing more broadly already. I know that at NIH you're getting these questions about metrics for impact, and I think it's all part of the same question, and goes back to my abstract and sort of the societal expectations. So I'm going to wind down and say, in spite of my comments about the future, I'm optimistic. So I don't want anybody to leave here not feeling optimistic. I don't want anybody who's way younger than me to decide that this is not the right career. Here's a great quote from Governor Lamb of Colorado. Major factors that brought health to mankind were epidemiology, sanitation, vaccination, refrigeration, and screen windows. So epidemiology is right in there with some of the things that have really impacted public health. Remember that graph I showed you about what was happening last century. And it was only the anthrax and 2001, if you'll remember, that got us a New Yorker cartoon, which is over here. And it was typically brilliant of you to have invited an epidemiologist. And fortunately, things seem to have gone beyond the point where if you say you're an epidemiologist, you get that question about skin. So I think we're making progress. Now, people often ask me about why do epidemiology? And I began life as a clinician epidemiologist, taking care of people with lung disease. And for those of you who know pulmonary medicine, there's three big diseases. There's asthma, there's chronic obstructive pulmonary disease, and there's lung cancer. And I can tell you, I don't know how many times I bronchoscoped somebody, looked down, they smoked, you knew the story, and saw the cancer, and they wake up and they go, patient would wake up and they'd say, well, doc, I've got cancer, don't I? And say, yep. And then they'd say, well, how am I going to do? Not so well. And of course, for all those smokers with these lung cancers, these were preventable. Some years ago, I took care of a patient whose husband was an author, and he wrote this about my encounter with them as she came to me with an incurable large cell carcinoma. And I think the point is made by his text. I mean, when you get to disease that you can't do anything about, you say, well, let's do something about it. And I think that is the power of epidemiological evidence. So this is saving lives, or trying to, one at a time. At Hopkins some years ago, when they did the Bloomberg thing, they tried to explain what public health is, and came up with the tagline that probably many of you have seen: protecting health, saving lives, millions at a time, which I think is what epidemiology has the potential to do. So hopefully with big epidemiology, we'll be saving more lives faster, more at a time, or whatever. Although, as I pointed out to the dean, to Al Sommer, we actually don't save lives. We avoid DALYs or something like that, since inevitably we're all going to die. But somehow, saving DALYs millions at a time didn't quite resonate. So again, thank you very much for the invitation. I'm honored to have been invited to give this lecture. And as we say, this is the end. Thank you.
I imagine that Dr. Samet will entertain questions.
Or comments, or disagreements. Uh-oh, Bob.
I think it was a great talk, John. The question, I guess, is that do you think that the United States is the place to do this, given the fact of the lack of a single-payer system for healthcare and a lot of other infrastructure elements that we don't seem to share with some of the rest of the world?
Yeah, it's a bit of a loaded question. So I think obviously I have to agree and disagree, because I think you've put your finger on an important point, that there are places where we could do many of the studies we want more efficiently because of existing systems for tracking people and health events. And I think Korea exemplifies that. I mean, in fact, some years back we went in with a grant to take blood specimens and store them. It turns out that every adult, I think 25 and older, has a physical every other year with a blood draw. And there's an example, an opportunity to think about putting away specimens millions at a time and doing some of the big kinds of things that we want to do. Of course, we have Kaiser and some other systems that people are working very hard to explore those kinds of opportunities. And then, of course, we have very populous nations like China, where cases can accrue very rapidly. So I think we're certainly going to see more and more important international players, and contributions in the literature trends would support that. Yes?
Yeah, hey, Jonathan, very nice talk. And I was just coming back to your tagline there, saving lives millions at a time. And I think about your introduction to epi with lung disease and smoking, and my own, and the fact that despite all the epidemiology we've done for ages, we still have countries that are not saving lives millions at a time despite the epidemiology. And I wondered if you'd have a perspective on that from big studies.
Yeah, no, thanks, Barry. I mean, I think this goes back to this sort of global level questioning, that global level issues that are on that diagram. And I think, in tobacco, there's been an opportunity for people to engage initially in the development of the Framework Convention, and now its implementation and tracking, and to look to a solution that is motivated globally to a problem that was defined epidemiologically. Perhaps there may be other candidates for this same approach, and people are thinking about this, multinational food corporations, for example. But I think I spent some time today talking to different groups of trainees about policy, and I think the question is how far one wants to go upstream from their science to move up those different levels of societal organization and get involved. I mean, I will say I find myself now very often involved with groups I didn't talk to before, those people in international relations, global governance, business, and so on, because they're critical, or media, they're critical to finding the solutions that do reach globally. And your paper in the American Journal of Epidemiology, well, it's probably a start, and it's probably maybe a piece of the scientific foundation, but then the question of how you go up, I think, is important. I know you're concerned about these systems implementation issues. Yes.
I appreciated your comments about big science and the need to share data and to pool data. But I'm struck by the slides you showed about the number of papers in these individual topic areas that come out every year, and how an individual could keep track of all of those ideas. And is there a way to pool those papers or somehow get that knowledge into a way so one person can actually understand what they need to understand to answer an impactful question, or do they just have to get into giant consortia and pay the price of collaboration to come up with something that's meaningful?
Yeah, no, I mean, I think the question, I think I'm going to sort of reframe it. I think the question, in a way, is how do we track the accumulation of evidence and know what we have? And I think in our current system, it's clearly very difficult to do that. I mean, when you have a new paper, is it your obligation to update some sort of living cumulative meta-analysis? For example, how do you place evidence, new evidence, within a broader construct? When we began to do these national level studies, I felt that we were, in a way, getting beyond sort of what had happened before, where people, for example, did time series in this one city at a time. But if the burden is on individual authors, each time we publish, to say what we've added, which we probably should be, as you point out, that could become a very big to impossible job. And I think this goes back to the sort of meta-knowledge question and how we're going to think about the aggregation issue.
Thank you. That was a very provocative talk. And you pointed out that there's big on the side of the question in the epidemiology, but also often there's big on the side of what might be the industrial or the commercial or the social groups that might want a particular answer. And I wondered if you could speculate on whether the phenomenon of more transparency, availability of data on the internet, sort of this other big trend that has gone along with sizing of studies, is going to shift that balance. That is, if we do these very large studies, and not only that, if the data become more readily available for many other investigators to revisit our question, is that going to be good, bad, indifferent, neutral? Is it going to be completely case-by-case dependent? Sort of looking back over many years of tussling with not just the cigarette industry, but other big players. What about big data sharing along with big epi and kind of big politics?
I think you've given roughly the answer to the question that I would give. I mean, I appreciate the issue, and some of you may be familiar with the Shelby Amendment, which came along in I think 1998. There was an amendment to the Circular A110, the OMB document that describes how research should be done, and this came out actually because of the use of EPA of the Harvard mortality study and the American Cancer Society mortality study in looking at particulate air pollution. The argument was made by the industrial stakeholders that because EPA relied heavily on those data, they should be publicly available. And then what followed was this change to the Circular A110, essentially saying that research that is policy relevant, and there is a description of what that means, if the data were collected with federal funds, including, I think, as much as 1 cent or only 1 cent, then the data needed to be made available if people wanted them. And I think, the concern was, would there be the possibility of sort of stakeholder analysis induced confusion? I have this slide about something called Gibson's Law that says for every PhD, there's an equal and opposite PhD. And I think, there's this sort of concern that for every analysis, there could be an equal and opposite analysis done by the right data person. I'm not sure I've seen that happen yet. I think it's a real concern. But I think what we are going to need to think through, and I think I alluded to this, is with all this data available, what is the role of the epidemiologist in using it, in collecting it? Who are the epidemiologists of the future? I mean, I think those are really important issues. I think we need to watch and somehow better understand what's going on. And perhaps the right sociologists or others are going to be tracking us and understanding what is going on, as we change culture.
Dr. Samet, thanks from all of us, and I hope that the rest of you will join Dr. Samet and me in some light refreshments outside. Thank you.